Next speaker, we have Dr. Sujoy Majumdar. He is Honorary Head, Department of Diabetology, GD Hospital and Diabetes Institute, Kolkata. He's Senior Visiting Consultant and Endocrinologist at PLS Hospital, Kolkata, and Examiner for MRCP, Clinical Examinations in India. He's Vice Chairman of Indian Chapter of Royal College of Physicians of Ireland and Vice President for Diabetes Awareness and You Day Chapter. He is President of Rotary Club of Kolkata Pointers. He has 25 publications in national and international peer-reviewed journals and one chapter on acromegaly and diabetes in Diapedia, the online textbook of diabetes of European Association for Study, that is EASD, and he has 7 book chapters. And for next talk, over to you, sir. Sir, please unmute yourself.
Yeah. Good afternoon, everybody. And I believe I'm audible and visible.
Yeah. Perfectly. All right.
Yeah, I'm sharing my screen. So okay. So I would like to start with a big word of thanks to Dr. Banshi Sabu for inviting me to be present for this meeting again another time. And in fact, I've been a part of DiaCare several times in the past, and I've always enjoyed the hospitality of Dr. Sabu and his team. So no special thanks for them. Now, the topic for today's discussion is somewhat very interesting. And when Banshi asked me for my opinion, I thought this is something which needs a bit of discussion. Because our background thought process is always like this, that whenever we're thinking in terms of hypoglycemia, the only thing that comes to mind is as a part of management or as a complication of diabetes. But unfortunately, or I should say surprisingly, hypoglycemia can occur in a lot of other non-diabetic conditions. And this is something which I'm going to discuss today. And for that, I'm going to take you through several real-life case scenarios, one after another. So this is the first case. Mr. Sen, a megalomaniac 45-year-old accountant, he awoke one morning with uneasy dreams. He was non-diabetic, hypertensive, and a heavy alcoholic and smoker. He found himself transferred into the bed into a giant cockroach. That's what he felt, or feeling very weird. He had recurrent episodes. These were sporadic, but occurred frequently in the mornings and were relieved by breakfast. And the most recent visit occurred 2 days prior to his clinic visit when Mrs. Sen found her husband happily taking the morning shower in his pajamas and shirt. So he was behaving in an absolutely irrelevant manner. So this was what his presentation was like. So is this hypoglycemia? Well, if you look up at the workup for Mr. Sen, what we can find out that his fasting plasma glucose done on a subsequent day was 45. And the other workup, including the liver function test, the urea and electrolytes, and the chest x-ray and hemogram, everything was essentially unremarkable. So essentially, we're dealing with a case of spontaneous hypoglycemia. Now, what exactly do we mean by the spontaneous hypoglycemia? So this is basically the definition of a spontaneous hypoglycemia. It's a clinically relevant hypoglycemia that is characterized by this Whipple's triad. And I'm pretty sure in this audience, we are all familiar with this Whipple's triad. So basically, the patient has got characteristic neuroglycopenic symptoms. What these are, we're going to discuss later on. Patient has got a low blood glucose. Usually, it's less than 70 milligrams per deciliter. And the symptoms are usually resolved with oral glucose treatment or by any treatment which brings the glucose back to normal. So it is very important that this low blood glucose with symptoms must be present to define spontaneous hypoglycemia. Now, is this hypoglycemia fasting or postprandial? There's always a question that comes to our mind. A fasting hypoglycemia is something which usually occurs more than 5 hours after the intake of the last food and indicates an underlying disease. So this is exactly what we're talking about by the non-diabetic hypoglycemia. Now, this does not mean that hypoglycemia doesn't occur in a fasting state in a diabetic patient. Certainly it does. But if the patient doesn't have any such underlying disease, at least apparently, and the patient presents with a fasting hypoglycemia, we have to think of some other secondary cause other than diabetes. Usually, diabetes doesn't present per se as a fasting hypoglycemia. And also, there's another issue known as postprandial or reactive hypoglycemia, which occurs usually 2 to 5 hours after the intake of food. And it usually occurs due to an exaggerated insulin response, as for example, and this is typically given the name a dumping syndrome, which happens because of a rapid transit of food through the gastrointestinal tract, so that there is an insulin release which occurs earlier than the blood glucose gets a chance to go up. Now, what is a clinically significant hypoglycemia? Why not just a low blood glucose? Now, this was a study which is actually nearly 40 years old today. So this was a study where people looked at the plasma glucose in men and women, normal men and women, during a 72-hour fast. And what did they find out? That the lowest average blood glucose demonstrated in men was something around 67.5 milligrams per deciliter. And in women, it dropped even further, 41.3. So as you can well appreciate, both these values, 67.5 and 41.3, are well below 70. And by normal definition of hypoglycemia, both these was classified as hypoglycemia. But this was not clinically significant. Why? Because the patients did not have any symptoms. And these were all normal human beings. So you could not think about something like these patients are having a hypoglycemia associated autonomic failure. That's why they're not having symptoms. No, these were all normal men and women. So that's why what was the conclusion of the study is that the average blood glucose of a normal individual can vary greatly between the different individuals. Some of them could end up having a very low blood glucose, but that does not define a hypoglycemia. So what is a spontaneous hypoglycemia? What is the first take-home message? A blood glucose concentration less than 70 milligram does not necessarily signify disease. And the second take-home message is that there should be presence of neuroglycopenia symptoms. So what are these neuroglycopenia symptoms? They include things like fatigue, headache, disorientation, slurred speech, a confusional state, and ultimately leading to a loss of consciousness. And disorders involving life-threatening hypoglycemia may be present in purely neuroglycopenic symptoms, such as bizarre behavior. In other words, what happened in Mr. Sen's case could be a typical presentation of a spontaneous hypoglycemia with neuroglycopenic symptoms. So the second take-home message from this is that not all bizarre behavior may be explained by hypoglycemia. Yes, here we have got a documented hypoglycemia, but that does not mean that anybody presenting with a bizarre behavior is having hypoglycemia. Why? Because before you come to rule out spontaneous hypoglycemia, these are things which need to be ruled out. Whether the patient is taking any specific drugs or any toxins, whether the patient has got any organ failure, whether the patient has got any infections or chronic malnutrition, or whether the patient is suffering from any hormonal disorders. It is last bit which will need a little bit of discussions, but other things, other bits I think all of you know. So basically the commonest glucose lowering therapy that produces hypoglycemia in a non-diabetic patient are insulin and sulfonylureas. Often insulin and sulfonylureas have been used for suicidal intent by family members of diabetic patient. So if such a patient presents with a hypoglycemia, this is something which needs to be ruled out. This is a known fact that insulin and sulfonylurea does produce hypoglycemia. What about the rest? Now, this is actually a big list. I'll not bother you by taking through this big list. But what is interesting to know that certain drugs like the quinolones, quinines, and indomethacin have been known to produce significant amount of hypoglycemia. Also, alcohol is something which has been known to precipitate hypoglycemia. Drugs like lithium, dextropropoxifen, and rarely some conditions like mifepristone, disopyramide, and others, they have been seen to be associated with spontaneous hypoglycemia. What about critical organ system failure? In fact, the commonest one that we talk about is renal failure. It is a #1 cause of hypoglycemia in hospitalized patients with or without diabetes. And this happens because of the decreased clearance of insulin. And this decreased clearance of insulin can happen because of a deteriorating renal function and also a decreased gluconeogenesis because of a decreased delivery of alanine from the muscle, which is responsible for this insulin synthesis. The other one is a fulminant hepatic failure, which happens usually in setting of an acute fulminant hepatitis, paracetamol toxicity, Ray's syndrome. But this is not usually seen with cirrhosis chronic hepatitis or liver metastasis. In other words, for a hypoglycemia to result from hepatic failure, that hepatic failure has to be acute. It does not usually happen in a chronic hepatic failure. And in severe heart failure, this has also been noticed, but the exact etiology is unknown. Other infections which can cause hypoglycemia, malaria, particularly in association with quinine therapy. But we must remember that overwhelming sepsis with severe infections usually causes hyperglycemia and not hypoglycemia. There have been reports of chronic malnutrition leading to hypoglycemia. Again, the mechanism is not very clear. It could be increased glucose utilization by muscle following a vigorous exercise. So these are the different causes of spontaneous hypoglycemia which can happen in non-diabetic individuals. Now let us move on to the endocrine cause of hypoglycemia. So if there is a deficiency of these two different sets of hormones like the cortisol or the glucagon and the epinephrine, these sort of hormones can produce what is known as a hypoglycemia in our non-diabetic individuals. The other one, relatively unusual one, is a non-islet cell tumor. But endogenous hyperinsulinism is probably one of the commonest causes, and the commonest cause of that is insulinoma. But there are other conditions, relatively rare ones, like the functional beta cell disorders, like nesidioblastosis, autoimmune hypoglycemia, and so on and so forth. So is the next question that we have to ask when dealing with such a patient is fasting hypoglycemia present? If you have ruled out all the other factors that I've discussed so far, and the patient is presenting with a spontaneous fasting hypoglycemia, think about insulinoma, insulinoma, insulinoma. So this is the first diagnosis that you have to think about. When you've ruled out all the other factors, what next? This non-islet cell tumor hypoglycemia can happen. This is something which we'll discuss later on. Happens as a paraneoplastic phenomena, and also autoimmune hypoglycemia. So these are the other endocrine causes of fasting hypoglycemia. Now, what is insulinoma? It's basically the bad boy of spontaneous hypoglycemia. It's a relatively rare 1 in a million case annual incidence. It's usually spontaneous hypoglycemia. It's usually localized in one focus, but around 10% of insulinoma can be multifocal, usually in association with multiple endocrine neoplasia type 1. Usually, it's a benign adenoma, very rarely malignant. It's rarely seen outside the pancreas, but in around 1% patient, we have cyclomacross insulinoma, or there is insulinoma outside the pancreas. And most of these insulinoma are very small. In fact, 30% are less than 1 centimeter. And this is classically associated with a fasting hypoglycemia. Now, one may wonder, why really bother about something so rare? The answer is because miss it, it can kill your patient. Not from anything else, because as I told you, the tumor is usually benign, but from a persistent hypoglycemia, which can have all the deadly complications and sequelae of hypoglycemia. So insulinoma, the clinical presentation is again primarily with the symptoms of neuroglycopenia and, sorry. I'm sorry. So basically, if you go back again to the case of Mr. Sen, who was taking a shower in his pajamas and short. So if you now analyze all his symptoms, he has got all the typical neuroglycopenic symptoms like confusion and bizarre behavior. And it's provoked by fasting, and it's relieved with orange juice and breakfast. So it fulfills all the typical criteria for Whipple's triad. So obviously, this gentleman was suffering from spontaneous hypoglycemia. So what do we do from there? How do you diagnose? The gold standard for the diagnosis is a 72-hour fast. Now, how do you do that? So basically, the basis is demonstration of an inappropriate endogenous insulin production in the presence of a clinically relevant hypoglycemia. That is Whipple's triad. And what is the protocol for doing a 72-hour fast? Basically, you have to hospitalize the patient. This is a test you cannot do at home, and fast the patient up to 72 hours. The patient can have just pure water and nothing else. Ensure that the patient is not being smuggled in to have any food from outside, because often the patient will feel hungry. You check the blood glucose every 2 to 4 hours and monitor for the hypoglycemic symptoms. And in the presence of symptoms of hypoglycemic symptoms, or in the presence of a documented low blood glucose, as you can find out from capillary blood glucose, draw at least 2 sets of bloods for blood glucose, serum insulin, and C-peptide, and subsequently give the glucose and check for the resolution of symptoms that is confirming the Whipple's triad. Some of these patients you may have to stop early if there's more than 3% of body weight loss following the 72-hour fast. And the sensitivity of this test in picking up insulinoma is more than 95%. So basically, how do you distinguish between insulinoma and surreptitious insulin use? What about somebody who is using insulin surreptitiously to produce hypoglycemia? So when an insulinoma, the glucose is low, the insulin is high, the C-peptide is high. When it's a surreptitious insulin use, the glucose is low, the insulin is high, and the C-peptide is low. And this is because with exogenous insulin administration, endogenous insulin production and production of C-peptide and proinsulin is suppressed. So the C-peptide levels are low. What about if it's a sulfonylurea? What happens when it's a sulfonylurea-induced spontaneous hypoglycemia? The glucose is low, insulin is high because of the stimulation by sulfonylurea, and the C-peptide is also high. So this is essentially the difference between insulin-induced hypoglycemia and sulfonylurea-induced hypoglycemia, where the C-peptide level is high. But then the issue comes regarding the distinction between insulinoma and sulfonylurea, because in both these conditions, the glucose is low, the insulin is high, and the C-peptide is high. So how do you diagnose? So you tell them apart by doing a serum or urine sulfonylurea screen and find out whether the urine contains a sulfonylurea metabolite. The final localization of an insulinoma comes from the CT scan of abdomen. This was the CT scan of abdomen of Mr. Sen, which showed the presence, as you can see here, the area of insulinoma. And basically, these patients, as I mentioned, have got very high insulin levels, and anything like a spiral CT or an arteriography can pick up this area. Ultrasonography was used in the olden days, but not a very good treatment of choice. And once you have localized the tumor, the next treatment is enucleation, and recurrence at 10 years is enucleation. However, this is not, in most of the cases, it does cure the patient, but there is actually a risk of recurrence at 10 years. And this is around 6% at 10 years and around 10% at 20 years. So once the patient had an insulinoma, this patient should be kept under follow-up with periodic regular reviews. Now, Mr. Sen underwent an enucleation and the symptoms resolved completely. And this patient, as I told you, he has been free from symptoms for the last 14 years. As I shown in the CT, he had the symptoms in 2008, and now he's perfectly all right. Even after 14 years, he's doing perfectly all right. Let's move on to case number 2. So this is a 55-year-old male gentleman, known hypertension, which was poorly controlled. He was admitted to our National Neuroscience Center, that is NNC, which is one of the intensive neurocare units of the PLS hospital, with a right middle cerebral artery infarct. He was a heavy smoker, and he presented with recurrent hypos, and he was extremely lethargic and listless. Case number 3, a similar patient admitted with a left middle cerebral artery infarct, known hypertension. He developed a CVA after an episode of diarrhea and was admitted with a gross dyselectrolytemia, sodium of 115, potassium of 2.9. And during his stay in the hospital, he was troubled by recurrent hypos. He was extremely lethargic and was unable to communicate despite having no speech difficulty. Case number 3, Mr. Gosal, a 78-year-old widower male, lived with his nephew, hypertensive for 20 years and dyslipidemic for 10 years on adequate treatment. He had 2 CVAs in 2005-2006. In 2006, he was admitted with hypoglycemia, and again was noted to have an extensive left internal capsule and basal ganglia infarct. Several hypoglycemic episodes in patient, alert but vaguely responsive even when clinically stabilized. He looked depressed. So one common factor about all these 3 cases was that they had presented with an infarct. They did not have diabetes. They had background hypertension. One of them had dyslipidemia as well. Now, during an episode of hypoglycemia, when the lab glucose was less than 4, this was the result of the different pituitary hormone profiles, the growth hormone and the cortisol. And as we can see in all 3 of them, both the growth hormone and the cortisol levels were suppressed. So obviously, these patients were suffering from some degree of hypopituitarism. Now, just a bit of a statistics, the average annual incidence of hypopituitarism is 4 per 1 lakh, and hypopituitarism usually develops predictably, with growth hormone deficiency characteristically preceding the gonadotropin deficiencies and subsequently followed by a depletion of the TSH and acetate reserves. So both growth hormone deficiency and the ACTH deficiency can cause spontaneous hypoglycemia. These are the causes of hypopituitarism which can happen. Important to note that a cerebral infarction, like what happened here, also causes hypopituitarism. Now remember something, all these patients had cerebral infarcts in the middle cerebral artery trajectory. As we all know, the anterior cerebral artery drains into the circle of Willis and supplies the middle cerebral artery. So if the circulation of the circle of Willis is compromised due to any reason whatsoever, that can also lead to what is known as a subclinical pituitary hypoperfusion, pituitary ischemia, and in the long run, pituitary infarction. And it is seen from this particular study that isolated growth hormone deficiency can happen with multiple pituitary hormone deficiencies. So all these hormone deficiencies, particularly ACTH deficiency and growth hormone deficiency, are well known to produce hypoglycemias. So basically, these are the ways by which you can diagnose it in such patients, going for insulin tolerance tests or the growth hormone receptor hormone, arginine or glucagon, clonidine tests. And this is how you do go for a growth hormone assessment. And some of the biochemical markers which might help here is the IGF-1 and the IGF-BP3. The gold standard is ITT, but again, this requires a very intensive setup and a properly trained technicians to do it, and should be avoided in patients who have undergone a cerebral infarct or a myocardial infarct. It basically distinguishes the growth hormone deficiency from that due to aging and obesity. And as I mentioned, should be performed in units adequately experienced. It's contraindicated in non-ischemic heart disease and seizure disorders. And this is what an insulin hypoglycemia test, this is how it differs. Basically, if a patient is normal, this is what, I'm sorry. If the insulin, as you can see on the left-hand side of the panel, we have got the normal response of the plasma glucose, cortisol, and growth hormone with following hypoglycemia. In a hypopituitary state, with both the cortisol as well as the serum growth hormone, there is a flat response. So this is one of the ways by which you can find out whether the patient is really having a hypopituitary-induced hypoglycemia. So what happened finally in these 3 patients? So case 2 and case 3 were started on growth hormone and cortisol replacement. Case 4 could not afford a growth hormone replacement. It marked improvement in alertness, and for at least 2 to 3 years follow-up, these patients were on the growth hormone and cortisol replacement. There was reduced incidence of hypoglycemia. The alertness improved, but the neurological status, including the neurodeficits resulting from the stroke, it was unaltered. But despite that, the patients looked much better. And there was an increase in the muscle bulk in these patients. There was reduced hypos. And generally, the patients were doing fine. And they were followed up for the next 5 years, and reasonably, they're doing pretty fine. Another condition which can lead to spontaneous hypoglycemia in a non-diabetic patient is adrenal insufficiency. It usually produces mild hypoglycemia in adults, but in children, it can be severe. Primary adrenal insufficiencies can occur in conjunction with type 1 diabetes, and it can be present with a decreased insulin requirement and frequent hypoglycemia. And the mechanism is usually the decreased delivery of the gluconeogenic precursors to liver and or decreased synthesis of epinephrine or decreased induction of the N-methyltransferase. So adrenal insufficiency in children may present as spontaneous hypoglycemia, particularly in conjunction with type 1 diabetes. The important point is that hypothyroidism and early diabetes mellitus usually does not cause a spontaneous hypoglycemia. Early diabetes mellitus can present with a reactive hypoglycemia, but not with a spontaneous fasting hypoglycemia. Then we have got other non-beta cell tumors. Again, that list is not a huge, the list is big, but the incidence is much less. Large mesenchymal tumors like retroperitoneal sarcoma, intraabdominal and intrathoracic sarcoma, mesothelioma, these can all present with hypoglycemia. Hepatocellular carcinoma, adrenal carcinoma, malignant carcinoid tumors, pheochromocytoma, and some certain lymphomas, myeloma, and leukemia. They can all present with hypoglycemia. But as I mentioned, the incidence of this last, the hematological malignant disorders are relatively extremely rare. This leaves us with a really, truly weird cases of fasting hypoglycemia. One of them is the nesidioblastosis, or the islet cell hyperplasia. It represents a hyperplastic process of budding islet cells from ducts, or this is known as nesidioblastosis. And nowadays, this is interpreted as a precursor to MEN, or multiple endocrine neoplasia type 1. And heterozygous knockout of the MEN1 gene in the mouse show multiple giant hyperplastic islets that precede the insulinoma. So this actually could be one of the precursors of an insulinoma. And persistent hyperinsulinemic hypoglycemia of infancy is, in these infants have an identifiable genetic mutations in the sulfonylurea receptor 1, that is SUR1, and also in the KIR6.2 or in the glucokinase gene. So these patients are, because of this genetic mutations, they can present with increased tendency of hyperinsulinemic hypoglycemia in infants. Then we have got this autoimmune hypoglycemic syndromes. It is usually because of the anti-insulin receptor antibodies. It was first described in individuals with extreme insulin resistance. However, they can be seen in association with type 1 diabetes. And these are characterized by extreme hyperglycemia, alternating with refractory hypoglycemia. The hyperglycemia can shoot the blood glucose more than 500 milligrams per deciliter. On the hypoglycemia, this refractory hypoglycemia can shoot it down to below 20. It's extremely rare, as I told you. Less than 100 cases have been reported in literature, and it typically causes fasting hypoglycemia. So the final take-home message is that evaluation of hypoglycemia in a non-diabetic individual is a serious brainstorming session. It's easy to diagnose hypoglycemia in a diabetic patient, but when you are dealt with, when you're coming across a non-diabetic patient, this hypoglycemia management becomes an extremely tough and brainstorming job. It becomes almost like a detective story, like what happened in the case of Mr. Sen. We have to think about non-endocrine causes first, like renal and fulminant hepatic failure, also sepsis. This can produce, these are more commoner causes of non-diabetic hypoglycemia. And adrenal diabetes, adrenal insufficiency, and hypopituitarism with growth hormone deficiency usually causes less severe hypoglycemia. But as I showed in those three cases, these are rare, uncommon, but not unknown. And do not forget insulinoma as a curative cause of spontaneous, severe, non-diabetic hypoglycemia.